problems. Good. Okay, so I'm Ross Muir. I'm one of the limb reconstruction and trauma consultants here. With my colleagues, we also run a regional bone infection service. I am not a foot and ankle surgeon, so if I've done anything woefully wrong, any of the more expert speakers can come and correct me. So I have that caveat from the start. I did spend a few years of my training working in the bone infection unit in the Nuffield Orthopaedic Centre in Oxford, which is an internationally renowned centre for bone infection. And so when I was given the title of this talk, I started looking back through some of the papers that were published from that institution over the times I was working there. So this is one from back when we were using a lot of Osteocet T as a local antibiotic carrier, 195 cases, 1 forefoot infection, 1 hindfoot infection, that whole lot. The first 100 cases that were treated there with Cerament G, 100 cases, 3 calcaneal infections, no diabetic foot. Long-term follow-up, exactly the same, no diabetic foot. So it got me thinking, is infection in the foot and ankle not a big deal? Well, if we think about how infection gets into the foot and ankle, the vast majority of cases are from direct inoculation from the outside world, and it's either because of our surgical procedures or because of ulceration in the foot, particularly in the diabetic foot. Just in terms of numbers in the UK, we have about 180 ankle fractures per 100,000 of the population. About 20% of those get open reduction internal fixation, and reported deep infection rates after ankle ORIF are between 1 and 7%. So that we should be expecting in the UK between 500 and 1,000 infected ankle fixations a year. That number pales into comparison, however, compared to diabetic foot infection. So there's an estimated 5.8 million people in the UK living with diabetes. They have a significant risk over their lifetime of foot ulceration, and over 20% of diabetic patients that get foot ulcers will go on to osteomyelitis. So this is now a pool of potentially hundreds of thousands of patients for our infection service. This was back in 2017. The NHS was spending over 900 million a year on diabetic foot. We spend more now, we're still not very good at it. In fact, foot and ankle infection is probably the biggest numerically the biggest orthopedic infection problem that we have, but it's very poorly published, and all the big case series tend to avoid it. When we think about osteomyelitis, the thing we're trying to deal with most of all is this biofilm, which is this sort of protective community in a layer of mucopolysaccharide that planktonic bacteria like to form, particularly in areas of poor perfusion, devitalized bone, and around implants. And of course, that describes exactly those patient populations that I've just mentioned. So these are ideal patients for biofilm formation. And unfortunately, that means it's really hard to treat infection in the foot and ankle. So if you want to publish series that show really good long-term results, probably don't treat diabetic foot. The reason it's so difficult is when you think about our surgical principles for treating osteomyelitis as a whole, I think preoperatively you need to make a diagnosis. So is there an infection? What bone is it in, and what part of the bone am I treating? And you then need to optimize your patient to give yourself the best medical chance of treating the infection. Once you've done that, you start going through your surgical steps. And each one of these steps has specific extra complications when you're operating in the foot and ankle, and particularly the diabetic foot, compared to your average punter and other areas of the body. And we'll go through them all in a minute. In terms of the diagnosis, in the last decade, there's some quite good international work that's developed consensus criteria for the diagnosis of osteomyelitis, of fracture-related infection. So this is the FRI group from a few years ago now. And so they can come up with major and minor criteria, some of which are preoperative, some of which are postoperative, and you can develop a nice flow diagram of when you should be operating, when you should be investigating, and how you confirm your diagnosis. In diabetic feet, of course, pretty much all of them have an ulcer. So the presence of a break in the soft tissue is no longer particularly useful. And there are relatively recently these international guidelines that have been set out. They are somewhat more woolly than the FRI and the osteomyelitis ones. There's a number of tests that they do talk about. So the probe to bone test, which has been in and out of fashion in the foot and ankle world, I think. But they felt overall it did have a reasonable sensitivity and specificity. So if you can, with a blunt probe, actually go down and touch bone, or you can see visible bone in your ulcer, it's probably got a high chance of being infected. If your conservative treatments are failing, if you see progressive bony lysis, then you probably need to look at further investigation. The trouble is the numbers are so big in diabetic foot ulceration, we can't fully investigate all of them, because probably the best advanced imaging that we have for diabetic foot is the MRI, and we tend to use gadolinium contrast when we're requesting these. We just can't MRI everyone because it's thousands and thousands of patients with foot ulceration. When we do MRI the patients, what we're looking for particularly are we're looking for communications of the ulcer tract up to the bone. And you can trace it as you scroll through the slices. We look for collections in the soft tissues, and it can give us an idea about the extent of osseous disease as well. But even MRI is fraught with complication because, yes, osteomyelitis will give you bony changes on MRI, but so will an active Charcot. And both of them present with hot red feet. Both of them will show edema on a T2 image. Both of them will show changes even with gadolinium contrast. There are some subtle differences in terms of the distribution that can point you in the direction of one being more likely a Charcot process, one being more likely an infectious process. But you cannot ever definitively differentiate the two on any imaging that we have, which creates problems with diagnosis. But once you've decided as best as you can that you think this is a deep infection, you then need to optimize the patient. And as an orthopedic surgeon, this is something I'm bad at because I don't know much about glycemic control. I'm no good at improving patients' perfusion. Admittedly, TrueLock Elevate may change that, but we'll see, Alex. So this is where, as the previous speakers have mentioned, the MDT becomes very important. I need my colleagues from other specialties, the medical colleagues, the podiatrists, the vascular surgeons, to try and do everything they can to optimize this patient so that my surgery has a reasonable chance of success. And without this, I think you're really on a hiding to nothing. When we eventually get your patient to the operating theatre, the principles that we go through, and this is for all osteomyelitis, but with sort of specific nods towards diabetic foot. So we would start our operation fairly routinely by excising all of the sinus tissue and the unhealthy skin around it. And we will then extend that so we get a nice exposure of the bone we're trying to address. In the foot and ankle, skin is a precious commodity. There's not a lot of spare to go around. So we are sometimes having to be a bit more sparing in terms of our excision of soft tissue compared to other areas of the body where we can be a bit more aggressive. When we get down to the bone, the first thing we want to do is take deep samples to try and identify our causative organisms. One of the other issues with diabetic foot infection particularly is it has a far greater proportion of the patients that are polymicrobial, so more than one organism involved, because the insides of your shoes are fairly stinky places. And there are higher resistance rates as well in the diabetic foot compared to the rest of the body in general. So we really want to know what we're dealing with so we can target our antibiotics to that. We have a sampling tray a bit like this. It also has 5 scalpel blades on it. And we will take 5 clean samples from around and inside the bone that we're treating, using a separate clean instrument for each sample. We don't routinely use pre-op biopsies. We certainly don't use swabs of ulcers. Our feeling in our unit is that they are very poorly representative of what's happening actually within the bone. I know that is somewhat contentious in the foot and ankle community, so we can debate that later. But we don't believe in those preoperative biopsies. We use a no-touch technique, so the only thing that is going to touch that sample are the clean tips of that instrument that you're using to take it. Nothing else should be touching it. And we send tissue samples, preferably bone samples, because they are most representative. And we will send them from microbiology and histology as well. If you have the money for it, you can sonicate any implants that you take out. We don't have funding for that, but it does slightly raise your pickup rates of bacteria. And we send 5 samples routinely, plus one or two for histology. And we do that because of some nice work by one of my former colleagues, Maria Dudareva. So she showed that as you increase the number of samples you take up to 5, your pickup rate of the causative organism goes up. When you get beyond 5, actually it plateaus. You don't pick up any more bacteria, but your false positive rate certainly does increase. So it becomes actually detrimental to take 7 or 8 or 10. So we go 5, maybe 6, and then we stop. And at that point, we start our debridement of the bone. And we'll start it by removing any dead or sequestered bone, and we hopefully will have seen and planned that on our preoperative imaging. And then for corticomedullary disease, where it's going through the bone into the medulla, we'll expand the cloaca, the hole in the bone, until we have good access to a medullary cavity, and keep debriding until we get to a point where we think we have healthy bleeding tissue throughout. Now, in a tibia or a femur, that's reasonably practical. As you get into the forefoot, the bones are really, really small. So the reality is, if you have a case like this, so this is a fairly simple foot infection. So it was a diabetic patient. He had ulceration under his now destroyed 5th MTP joint. On the MRI, he's got, I'll use the, have we got the pointer? Let's grab the pointer. So he's got communication of the sinus through to a soft tissue collection. There's signal change going up the bone to about mid-shaft. By the time we debrided all this, there's a little floating distal phalanx, which you can't really leave. So cases like this do end up with a ray amputation. You do end up having to sacrifice, and partly that's in order to get the soft tissues closed in that area. So we are sacrificing bone more frequently probably in the foot than we do in more proximal larger bones. Stability is really important in infection. So if you leave bones wobbling about, they tend to become more inflamed, they bleed more, and that process encourages recurrent infection. So we like to stabilize any segments of bone that are moving. We always have a choice of doing this with internal or external fixation. None of us are super keen on putting metalwork into infected areas, but you can use internal fixation in the face of infection if you have a good host and a sensitive organism and good soft tissue coverage. And of course, diabetic patients are none of those. So acute internal fixation in the face of infection in diabetic foot is not really very recommended in my eyes. So we do end up using external fixation where we need to stabilize. The other thing we have to do, as has been mentioned before, so we have to correct the deformity. They've developed this ulcer for a reason. If we just treat the infection and leave them with this big Charcot deformity of their midfoot, if we, by some miracle, get it to heal, the same process is going to happen again because they've still got a deformity that will give you a new ulcer and a new infection, and you've wasted your time. So unlike the rest of the body, we're often correcting deformity at the same time as treating infection, which gives us sort of two complex things to deal with simultaneously. If this will advance, yes it will. So this is an example of that. So this is a lady who actually works in a hospital not too far from here. She had this Charcot process, dislocated her midfoot, and only presented to our unit when her talar head had come out through her medial plantar skin and was grossly infected and looking very unhappy. It was sort of her talus was half eaten away by this point. On the MRI scan, this is T2 and T1, I think. So there's a widespread bony involvement here. Is that all infected? How much of that is Charcot? It's very difficult for me to tell, to be honest. If I take out all that bone, there's essentially no foot left. So that's not really an option. So we to an extent operate with the assumption that some of it is still Charcot, and that we may potentially not be debriding some of the contaminated bone. But for her, essentially what we did is excise the talar head and excise a wedge of tissue across her midfoot, and then exactly as you did in the workshop just through there, put her in a really nice butt frame. And with the butt frame, we were able to correct her deformity, bring her foot back into a nice normal position. Over time, so by doing that correction, it also helped close down the medial soft tissues. So we were at least able to partially close them. There was an area that we had to allow to heal by secondary intention with a VAC dressing. But when she eventually healed, she could then go on to definitive internal fixation just to stabilise that midfoot in place. Her talus pretty much collapsed and dissolved, so she ended up with a hindfoot nail as well. Thinking about soft tissues, so I mentioned earlier, so you don't have a lot of spare soft tissue in your foot. So the teaching in osteomyelitis in general is that we want to have a nice, healthy, airtight tissue closure over your treated area, because that gives you the best chance of the infection going and not getting reinfected. And if we can't close primarily, then we're fortunate enough to have a few plastic surgeons that we work with, and whilst they are divas, they are very useful, and they can sometimes offer us either local fasciocutaneous or muscle flaps, skin grafts, and free flaps. If we can't use those, we do sometimes allow wounds to heal by secondary intention. We do use VAC dressings. I forgot to put BTM on there, but the previous speaker reminded me we do actually use BTM in the foot a reasonable amount, and we have had some good success with that. Sometimes we'll use an antibiotic bead pouch with Stimulan beads with gentamicin in if we're doing multiple stages of treatment for the soft tissues. But ideally, we want to get it closed. Unfortunately, the plastic surgeons have fairly limited options for flaps in the foot. And just as a few examples, so the medial plantar flap is one that we do sometimes use. It's based off the medial plantar artery, so that has to be intact and have a good flow for this to work. And that can swing round on its pedicle to cover much of the sort of lower part of the hindfoot. So you might use it on a case like this where there's a heel ulcer and there's calcaneal osteomyelitis. And this chap had a debridement of his osteomyelitis. We did a silo technique where we do multiple drill holes into the calcaneum and fill those with an antibiotic carrier. So I used Cerament for that, which had gentamicin and vancomycin in it. And then the plastic surgeons, so we start with an infected ulcer, a bit like that. They take this area of skin and rotate it 180 degrees on its vascular pedicle so it covers the defect over the heel, and then skin graft this area. And it looks pretty ugly for the first few weeks. Eventually, it can heal in quite nicely though. So that is a useful technique. Other local flaps that are described are the reverse sural artery flap for the hindfoot. Our plastic surgeons have stopped doing that because of high failure rates. They won't do it anymore. So if we don't have a good medial plantar, we don't have a lot of local pedicled options, unfortunately, with plastics. We can do free flaps as well. So this is a patient who was referred from a unit not too far from here. He'd had this calcaneal fixation after jumping over a wall, running away from the police for no reason whatsoever, and was referred to us when, that doesn't project brilliantly, so there's a screw there, and this is a dead piece of bone that's just come out the back of his heel, and it's all grossly infected and absolutely stinks to high heaven. So this gentleman ended up with a partial calcanectomy, and he had a free flap, and he healed very well. His infection cleared. He was actually quite pleased with the result, even though he no longer had an attached Achilles tendon. He didn't want to come for any secondary reconstruction, and he had this was a free ALT flap, which healed beautifully, but you're left with quite a lump on your foot. And if you have a lump here on your heel, or even worse, probably if you have a lump like that on your forefoot, it's very difficult to get a normal shoe back onto that foot. In theory, it's possible for the plastic surgeons to go back in and thin the flap down the line, but they're often reluctant to do that because they then can cause skin necrosis. So you're ending up with a foot that is covered, but it is not necessarily a hugely functional shape. And so because of that, free flaps have use, but it's somewhat limited in the foot and ankle, I would say. And then, this was mentioned in the previous talk as well, so dead space. So at the end of any one of our bony debridements, you often are left with a defect in the bone. If you don't fill that with something, it will fill with blood, which will form into a clot, which is then a very nice culture medium for any bacteria remaining to culture up again and cause a recurrent infection. So it's nice to fill that with something, and there's various options you have. It would be really useful if, as well as preventing a hematoma formation, you also put in something that was resistant to reinfection, or ideally does this, so delivers antibiotics locally to kill any bugs that we've missed. There are various antibiotic carriers on the market. Some of them will resorb and disappear completely. Some of them will remodel. So Cerament, which we mentioned before, has hydroxyapatite, so it does remodel into bone, which can be quite useful. Because the reality is, I'm not a perfect surgeon, and at the end of my debridement, this wound will still have some dead bits of bone in there. There will be some bacteria floating around. There will be some bits of biofilm still in there. I won't have got everything out, because the only way I do that is if I do an amputation at a higher level, realistically. That's the only way I can guarantee not to have those things. So I need antibiotics to mop up the rest of what I've missed. And our systemic antibiotics that we commonly use in orthopedics, a lot of them are absolutely rubbish at getting into bone. So flucloxacillin, we give it all the time. 10% of that actually gets into your bone. The rest is just floating around your bloodstream. Some do have better penetration, so rifampicin, ciprofloxacin's quite good. But generally, penetration into bone is not brilliant, and that's for normal bone. And diabetic feet definitely don't have normally perfused bone, so it will be even worse than that in your diabetic foot. So because of that, we very much like using local antibiotics. So these are calcium sulfate carriers that have antibiotics dissolved in them. That you, depending on the company you use. So as I said, I use Cerament, which mixes up into a paste that you can inject into bone defects, and it sets hard. I find it quite useful because of that. It will dissolve over a number of weeks and release a huge concentration of antibiotics into that local area without any systemic effects. So you can have enormous amounts of gentamicin, a vast concentration of gentamicin inside your bone without any detectable levels floating around your bloodstream. So you don't get the nephrotoxicity, you don't get the ototoxicity, all the bad stuff with gentamicin. And the level of gent that is produced is far in excess of what you would get with your standard PMMA cement. It's far in excess of the MIC, so the mean inhibitory concentration of most bacteria. It's high enough that even if there is some intermediate resistance to gentamicin, it probably still will kill the bugs. And it's actually often high enough to kill bacteria that are in fragments of biofilm. It's that higher level, so it's really useful. You can also get Cerament V that has vancomycin in it. You can also use a combination of the two, and we often tend to do that to make sure we've covered a broad range of organisms. So this burst dilution over the first 2 weeks is really useful, and then the levels drop to really low, so it doesn't promote resistance like, for example, PMMA cement tended to in the past. The other thing about using this high-dose local antibiotics is it's changing the way we think about systemic antibiotics post-operatively. So these are a couple of big pragmatic RCTs that were both run out of Oxford originally, but are international in terms of their patient collection. So Oviva was the first of them that came out nearly a decade ago now, and it was comparing essentially 6 weeks of post-operative oral antibiotics versus 6 weeks of intravenous, because the tradition before that is we would keep patients in and they would have 6 weeks of IV antibiotics to make us feel like we're adequately treating the infection. And they showed that as long as you're using an appropriate local antibiotic, 6 weeks of oral was non-inferior, so it had essentially equivalent results to the IV. And so since then, we keep patients in hospital a lot less. We send them home on oral antibiotics a lot earlier. It's better for your bed situation. It's better for health economics. So this was a very big step. The follow-up to that, which finished recruiting last year and has just been written up, and I think it's coming out in print fairly shortly, is Solario. So this is short versus long course systemic antibiotics after treatment of osteomyelitis. So that was comparing just 1 week of systemic antibiotics post-operatively, or I beg your pardon, so less than 1 week. So the maximum you're allowed was 7 days. So 1 to 7 days post-op versus 6 weeks. And again, it appears that the short course is non-inferior to the long course. So actually, there's no great benefit to a long course of post-operative antibiotics, with the caveat that, so the bacteria that you culture from all those samples we took earlier have to be sensitive to your local antibiotics that you've put in. And both of these studies excluded patients that had any metalwork in situ. So if you've got internal metalwork, this doesn't apply. So that's part of the reason. So frames are fine, but if you've got any internal metalwork, then don't rely on this. I'm not sure how that will be accepted in the diabetic foot world, but I think this is hopefully going to be a big step in how we use antibiotics post-operatively in the coming years. And then once you've done all your operation, then hopefully everything's healed. As I mentioned earlier, you have to stop the same process happening again. So that's why in surgery, correcting the deformity is a big deal. If you leave the patient with the same deformity, the same thing will happen. But they also need that ongoing follow-up from the MDT, so they need their diabetic control to be monitored. They need foot care. They need the orthotics and the podiatrists to be monitoring their feet to ensure that the same process doesn't happen again, or else you are again sort of wasting your time. So in summary, treating infection in diabetic feet is possible. It is also very challenging. There are issues at every step of the way. If you get into this sort of surgery, you have to accept that you are going to have failures, you have to own them, and you have to deal with them when they come. It is very much a condition where prevention is better than cure. So if you can avoid ever getting to that ulcerated, infected state, the patient is going to do far better. And your healthcare system is going to do far better, because the cost of treating each of these is I've tried not to work it out, but it is vast. The number of outpatient appointments, the number of interventions.